Well, good morning, afternoon, evening, depending on where you are joining us from today. My name is Lanare Tunji Ajayi, the CEO for Global Action Network for Sickle Cell and other inherited blood disorders. With me this morning, we have an excellent panel. We will be talking about the gaps in African region when it comes to inherited blood disorders. Amazing panel experts in these areas and in this region. And without taking much more time, I'll pass it to the amazing panelists, Megan Adediran, Mary Ampomah, and Titi Adeyemo, who will take it from here, introduce themselves, and lead us in discussing both the challenges and also solutions to issues facing the hereditary blood disorders in the African region. Thank you.
Thank you so much, CEO and President Larry. And also, I want to welcome everybody to this session. I want to welcome everybody to this GANSID Congress 2023. It's been exciting since yesterday. And today, as Larry rightly said, we are going to focus, this session is going to focus on Africa so that we can understand most of the issues, the gaps, and the action plans for Africa when it comes to hereditary blood disorders. Thank you so much. And welcome everybody to this session. If you are here, would like to know where you are connecting from. So kindly go to the chat box and put in the country that you are connecting from. And also make sure that you mute yourself and make sure that you mute yourself. And also we have other languages. So if you are not so familiar with English, you can opt for French or Arabic as it pops up. Thank you so much. So I would like to introduce myself. I'm Dr. Mary Ampomah. I'm a clinical psychologist by profession. I've been in sickle cell advocacy for 13 good years in Ghana. I am a lecturer at the University of Health and Allied Sciences, and I've been advocating for people living with sickle cell disease, as I said, for 13 years, all because when I was young, 3 of my good friends, they died before 10 years. And it was during my adulthood that I realized that, oh, okay, they died because of sickle cell. So I have purposed in my heart that nobody would die of sickle cell, not knowing their status in Ghana. So this is my passion, this is my motivation. And I was also the former CEO for the Global Alliance for Sickle Cell Disease organization. So thank you so much. Before we move on, I would like my other panelists to introduce themselves. So I will go to Dr. Titi Adeyemo for her to introduce herself. Then Megan will continue. Then we can start the session. Thank you so much. Please unmute. Titi, please. Dr. Adeyemo.
Yes, so thank you. So thank you, Mary. And thank you, GANSID. For this opportunity, and I'm very glad and honored to be part of this discussion, this global discussion on hereditary blood disorders and the actions that we can take to change the narrative. So I am Titi Adeyemo, Professor of Hematology in the Department of Hematology and Blood Transfusion, Faculty of Clinical Sciences, College of Medicine, University of Lagos, and a consultant hematology to the Lagos University Teaching Hospital. My research interest is in, of course, the benign blood diseases, sickle cell disease, bleeding and clotting disorders, and blood transfusion. I'm currently principal investigator or co-investigator for some funded collaborative research in sickle cell disease, anemia, and Haemophilia. So very glad to be here.
Thank you. Megan?
Yes, thank you and good morning, everyone. Thank you to GANSID. It's a privilege to share this high panel with people that I admire in the community, especially Professor Adeyemo, who has been very, very close to my heart. And also nice meeting you, Mary. My name is Megan Adediran. A public administration by profession, but for the past 18 years, hemophilia has been the profession that I've actually been practicing. I've been advocating for persons with hemophilia and other inherited bleeding disorders because I myself, with clinical features, I'm also a person with hemophilia, though Dr. Adeyemo refused to put me on her register. But I actually have 28% of factor 8 activity, which makes me mild hemophilia. And I have 2 sons with severe hemophilia A. And that was the reason why I started advocacy for my sons. I come from a lineage where Dr. Mary spoke about 3 friends. My maternal family I lost 9 uncles to bleeding after circumcision that were never diagnosed. So it was in my family. And when I had my first son and he was diagnosed, I decided to be a voice. I am currently the president of the Haemophilia Foundation of Nigeria, and I'm also a member of the board of directors of the World Federation of Haemophilia. So it's nice to be here this morning to talk about the gaps in Africa and how we can move forward from where we are. Thank you.
Thank you so much, Megan and Dr. Adeyemo. Now, I would entreat all panelists to put in their questions. If they have any questions, if there's anything they want to react to, they can use the reaction button, but they should make sure that their questions are put in the question and answer column. So thank you so much. I'm still expecting you to put in where you are participating from, the country that you are participating from. Thank you. We have a quiz that we want participants to engage in. It's just a short, it's a 5 minutes. So we would like to present it so that you can engage in it. You can put your answers in the questions and answers button for us to see. Thank you so much. Dr. Adeyemo, can you please share the screen on that so that participants can engage with those questions? Thank you.
So can we see? Can you see my screen?
Yes, we can see.
Yes, we can.
All right. Okay, so we'd just like the participants to put the answers to some of these questions. How sickle cell disease or any inherited blood disorder impact them, that they are living with it, or they care for someone with sickle cell disease, or they have the trait or the carrier status for any of the inherited blood disorders, or they are just a sickle cell advocate or an advocate for any of the inherited blood disorder. And if they are currently impacted, have they ever had genetic counseling? I'm actually interested in that question. How many of our people who have been impacted with sickle cell disease or any of the inherited blood disorder have ever had genetic counseling? And I think we can stop there. The first 2 questions for now. Thank you.
Can we still? I don't think a lot of them saw it. It was too brief.
You want me to share again?
Yes, for like.
Oh, okay. All right.
We should just copy. Maybe we copy the question and put it in the chat box.
Okay, so that may be an alternative so that it doesn't take much of our time.
Yes.
All right.
And then people can. Yes, someone is asking if they can. Yes, you can just answer in the chat.
Yes, if I may say, once you just put on the slide and people can just put their answer to the question in the slide. So folks, you can just say question number 1 and put the answer. Number 2, put your answer. So that way our panelists can see your responses in the chat. Thank you.
Okay, so it means it can be ongoing. So let's continue with this.
The slide is not showing, Dr. Ampomah, the slide is not showing anymore.
No, I'm putting the question in the chat box.
In the chat. Okay.
So that anybody that comes.
I just put the question in the first one in the chat with the options of the answers.
Awesome.
So I'll put the second one too, so they can see it and answer there.
Thank you.
So before we move on,
I think that works.
Yeah. Before we move on to our next session, I want to thank the GANSID team for putting this African workshop together. Thank you so much for the time and energy for us, because most of these hereditary blood disorders have their prevalence in Africa. So it is an opportunity for us to be here to have this educative and insightful session. So not wasting much time, I would like Dr. Adeyemo to share her slides as she presents on bridging the identification and treatment of hereditary blood disorders gaps in Africa. So thank you so much. And as I said, if you have any questions, put it in the questions and answers bottom. We would answer it later. Thank you so much. See you.
Right, so thank you very much, Mary, and for giving me the first slot. Okay, can you see my screen? All right. So over the next 15 minutes or thereabout, I'll be talking about bridging the gaps in identification and treatment of hereditary blood disorders in Africa. Again, I'm Titi Adeyemo from Lagos University Teaching Hospital. Okay, I have no actual conflict of interest to disclose in relation to this presentation. And this is just going to be my outline, a very quick one, looking at the overview of the burden of inherited blood disorder in Africa, the gaps in identification and diagnosis, the gaps in access to treatment, and the efforts at bridging these gaps at the continental and local levels, and then some key takeaways. Okay, so we know when we talk about the hereditary blood diseases, we're looking, also looking at malaria. In 1949, the British scientist Howden was the first that made a novel connection between red blood diseases and malaria. The genetic mutation that of these red blood disorders have persisted in certain human population, and the heterozygous individuals with heterozygous forms of these disorders, of this mutation, have certain protection against these disorders. So it has persisted because of this association with malaria. So it's common knowledge now that the inherited blood disorders are common in sub-Saharan Africa, though there's a lack of accurate and reliable data about their actual prevalence, the co-inheritance, because sometimes these mutations are co-inherited. or their overall contribution to childhood mortality and morbidity. No accurate and reliable data, but we do know that these disorders are very common. A few studies have looked at it. 2 out of 3 children were documented to have one hereditary blood disorder in Western Kenya, sickle cell traits, heterozygosity or homozygosity for alpha thalassemia, the HP22 genotype, the G6PD deficiency. Okay, all linked to some form of protection against malaria, or leads to some form of morbidity and mortality, contributes to morbidity and mortality in childhood in Africa. Among Malawian children under 5, a high incidence of these hereditary blood disorders was also documented. So a few data here and there have been presented, but overall, we still do not have very accurate and reliable data. Recently, a comparison looking at the birth prevalence of sickle cell disease among different populations, okay, still showed that the sub-Saharan African countries carries the majority, vast majority of the burden, almost 2,000 by 100,000 births in sub-Saharan Africa compared to South America and European countries. 5 countries in Africa bears the majority of the burden for sickle cell disease: Nigeria, Republic of Congo, Gabon, Ghana, Cameroon, having the highest rate and accounting for 30% of the 60% that Africa contributes to the burden of sickle cell disease. Haemophilia, a very rare genetic disorder. Evidence has shown that the incidence of hemophilia is constant in different populations. 1 in 5,000 males birth, okay, is expected to have, okay, the hemophilia gene. But with 18% of the world population, African represents less than 3% of the people, of the patients identified as having hemophilia. So there is a lot of diagnosis and identification gaps. And with respect to treatment, only 2 of those who have been identified have access to clotting factor concentrates. But the narrative is changing, and we're going to look at the effort that is being made to bridge these gaps. With regards to identification and diagnosis, diagnosis and care for people with hereditary blood disorders are heavily dependent on the availability of trained healthcare professionals and appropriate infrastructure and resources, which we know is grossly lacking in Africa. It is even more compounded in recent times with the economic emigration of trained healthcare professionals from the African continent. So the situation is even getting more difficult, more dicey. People do not have access to being diagnosed early. People do not have access to genetic counseling. We know that genetic counseling is key to guiding the patients through the economic, socio-economic, the psychological, the medical implications of having a genetic disease. It is grossly lacking. It's absent in almost all sub-Saharan African countries, even though it has been shown to be an effective method to decrease the impact of genetic conditions. The consequences of not being identified or diagnosed, consequences of late diagnosis, and also the consequences of wrong diagnosis, because that is also a problem we see in Africa because of substandard laboratory infrastructure. It's well known to those of us practicing in Africa. Okay, the under 5 death of people with sickle cell disease, for example, 80% of children born in Africa with sickle cell disease is said to die before their 5th birthday, which is consequence of delayed diagnosis, the unavailability of newborn screening, okay, denies these children the opportunity to have penicillin prophylaxis, to have care that they should, okay, and that leads to the overwhelming data we see on morbidity and mortality in Africa. Aside the gaps in identification, the barriers to quality care and management of hereditary blood disorders is also well known to a lot of us as working in the field. Management and care for persons with hereditary blood disorders heavily dependent on the availability of trained healthcare professionals, just like with the diagnosis and identification, appropriate infrastructure and resources. And this we know is grossly lacking. In Nigeria, for example, we had, by the WHO criteria, the numbers of healthcare workers compared to the population of 220 million people. It's highly inadequate. So people in this region do not have access. Majority of people in this region do not have access to trained healthcare professionals, especially trained healthcare professionals in the field of hereditary blood disorders. More so, the lack of services at lower level health facilities, the primary healthcare system, the dysfunctional primary healthcare system, or the inadequate primary healthcare system, okay, which is very important to effectively hamper, which are very important to effectively respond, okay, to this disease. So this lack of services hamper the effective response, okay, to the hereditary blood disorders that we see. Added to that is the cost of treatment for those that have been identified, the lack of insurance coverage. We know that interventions for the hereditary blood disorders are expensive. The cost of clotting factors, for example, with those with hemophilia, the cost of hospitalization, blood transfusion, and so on. In Nigeria, for example, about 7.2% of the population are enrolled in the National Health Insurance Scheme. Yet the monthly household ranged from about $27 to $716. Yet for monthly health expenditure for patients with sickle cell disease ranges from about $5 to $466 monthly. Yet these people are not insured. So we need to look at bridging this gap by looking at health insurance, because health insurance can be an invaluable tool that can help to ease the financial burden associated with managing hereditary blood disorder. You can't do out-of-pocket expenditure and expect to make an impact in dealing with the IBDs. Blood transfusion is a key treatment option for people with inherited blood diseases, whether in sickle cell anemia, whether for component transfusion, fresh frozen plasma, cryoprecipitate, for those with hemophilia. Yet, blood banks across many African countries do not have adequate supply of safe blood to support the treatment of treatment needs of people in the inherited blood disorder community. And you wonder, continent of over a billion people. So what are the issues in getting the blood units into the blood banks to be made available for people who have the inherited blood diseases? The population is there. So we do recognize that there are gaps that we need, that we can bridge. Added to that is the healthcare bias, the negative bias and stigmas that have been levied upon patients with inherited blood disorders by healthcare providers, the societies, researchers, and legislators. And of course, this bias impacts the funding. It impacts the attention that should be given to these disorders. Legislators, for example, in my country, Nigeria, think that they can legislate away sickle cell disease. They can just say, legislate and say people who have inherited, two people who are sickle cell carriers straight should not get married. See, that is just going to solve the problem. So, and then the world is now going genetics and genomics. And there is already a fear in the African continent about how we are going to be able to access. We know that genetic medicine generally provides a solution to genetic conditions, starting with the invaluable use of the family tree in diagnostics, and then more recently in therapeutics. The world is talking gene therapy for some of the inherited blood disorders. And we believe that genetic medicine innovation should be sustainable and should be equitable for all population. I was privy to some of the discussions we had yesterday, the enormous costs and resources that is required to do this. But we have to make it equitable. Access has to be equitable. People in Africa must also have access one way or the other. And in the words of my African brother, a renowned African geneticist, who is the current president of the African Society of Human Genetics, with Africa having the oldest population in the world, this is scientific imperative for the global community to invest in African genomic evaluation for the next decades to come. We all have to start advocating for greater application of genomics in Africa to benefit the global South, which has suffered from inequality in healthcare systems, limited research and funding. So advocating for genetic medicine in Africa has become an imperative. What are the efforts that has been made to bridge the gap so far? Well, the WHO had a response to the burden of hemoglobin disorders in Africa. The governing body adopted 2 resolutions. The first at the 59th World Assembly in 2006, and the second, a resolution on thalassemia at the 118th Assembly meeting of the WHO executive, where they call upon affected countries and the Secretariat of WHO to begin to strengthen their response to these conditions. An additional resolution was made on the prevention and management of birth defects, including sickle cell disease and thalassemia, and this was adopted at the 63rd World Assembly in May 2010. Specifically, what WHO is saying is that we have to increase awareness of the international community of the global burden of these disorders, promote equitable access to health services, provide technical support to countries for the prevention and management of these disorders, promote and support research to improve quality of life for those affected. The African Health Minister of States also have responded. They launched a campaign to ramp up awareness, to booster prevention and care, to curb the toll of sickle cell disease, one of the most common illness in the region, but which they have recognized is receiving inadequate attention. Okay, so sometimes in August of last year, they have met and released a communique on how they are going to, where they launched this campaign to ramp up awareness. I talked about the lack of access to genetic counseling and how genetic counseling is being a key process to helping people understand the condition, adapt to the medical, socio-economic, psychological, and familiar implication of having this genetic discussion. Without adequate genetic counseling, people who have inherited blood disorder do not respond adequately and they do not do well. So as we make effort in diagnosis, we have to combine it with genetic counseling. It is not enough to diagnose. I have, in my practice, seen a lot of people who have been diagnosed and they have not been able to navigate through having this condition adequately because of the lack of genetic counseling. Unfortunately, countries in sub-Saharan Africa are highly do not have access. There is a lack of genetic counselors, inadequate numbers of genetic counselors on the continent. A few efforts have been made, but they are just tips of the iceberg. We have seen a bit of some countries trying to introduce genetic counseling curriculum and courses to existing programs, training workshops, organizing training workshops. This has been done in Ethiopia. This is being done in Nigeria with the Sickle Cell Foundation, organizing a yearly training course, 2 weeks, 3 weeks training course, just to be able to make some impact. But we know that this is still a far cry from what we should have. People do not have counseling before diagnosis, after diagnosis, do not do well, do not navigate the condition, the disease well. More recently, the West African Genetic Medicine Center at the University of Ghana launched, and I think this is the maiden, okay, in fact, I think the only genetic counseling program, structured genetic counseling program, Masters of Science in Genetic Counseling in Sub-Saharan Africa. It was launched a couple of years ago, and we hope that with time we're beginning to see the impact of this as we see more and more qualified genetic counselors in the subcontinent. With respect to diagnosis, one talked about the challenges of infrastructure and resources, the equipment, the lack of power. Most of the equipment will run on power. Most of the equipment will need to have qualified and trained healthcare worker who can run this facility. And then for that reason, you have the availability of this diagnostic equipment or facilities as only designated hospitals, usually in tertiary hospitals or secondary care facilities. But we know that the majority of the people who are affected and impacted are in the community. So we need to bring access to diagnosis to the community. A lot of effort is being made into point of care testing for sickle cell disease, for example, so that you will not need to have electricity, okay, to be able to diagnose reliably and accurately people with sickle cell disease. And then you will also be able to diagnose more. And more recently, we have come to realize that this is what can work for us if you are going to do the newborn screening program, okay? We have to take newborn screening to the community. It has to be done at the primary healthcare level. We have to use a technology that is easy to use, easy to access, and at the same time cheap, and give us accurate and reliable test results. So a lot of effort is being made into point of care testing. Thankfully, a lot of them are now available. They are now being tested. Feasibility and acceptability studies have been done. Diagnostic accuracy has been determined. And policies is being drafted to use this point of care testing for newborn screening, okay, even for newborn screening, okay, at the community level, primary healthcare system, okay, to be able to diagnose and identify more children and have early diagnosis, prevent the consequences of late diagnosis. With respect to hemophilia, the World Federation of Hemophilia has made a lot of difference. I would say that 15, 20 years ago, it was like there's no hope. And I'm sure Megan is going to talk a lot more about hemophilia when she does her presentation. But WFH has been doing a lot of capacity building programs in Africa, and that has made a lot of difference. There've been a large network of healthcare professionals in Africa who are well trained in hemophilia care. The number of people who have been identified with hemophilia care, with hemophilia is increasing in sub-Saharan Africa. So we are still a long way to where we should be. There's also some improvement in care with availability clotting factor concentrates. almost or even more than 24 million units of clotting factor concentrate is being donated per year to patients in sub-Saharan Africa. But these are all still tips of the iceberg. With the efforts and collaboration, for example, with the Nigerian Haemophilia Foundation, the Nigerian government has included bleeding disorders in the national policy and strategic plan just a couple of years ago. So these are just baby steps. These are baby efforts that are being made, but there's efforts all the same. And we must appreciate these efforts, but we need to also realize that we need to do a lot more. And we have to start going beyond taking baby steps, okay, in changing the narratives. Some of the efforts, one of the efforts is also standardizing care for inherited blood disorders in Africa. The development of standard of care protocols and guidelines for sickle cell disease, for hemophilia, multi-level standard of care, for example, in sickle cell disease in Africa, okay, with the Sickle in Africa, SPACO-SADA consortium, the collaboration with the World Federation of Haemophilia to develop locally appropriate management guidelines for hemophilia. It's also happened in recent times. And these are efforts that are being made to change the narrative. Again, they are all tips of the iceberg, and we still have a lot to go. So I'll be rounding up my 15 minutes presentation, okay, by quoting our current Minister of Health. He made this declaration in 2019 when he said, "Ignore no more, reimagining the primary care to combat sickle cell disease in Africa." Okay, he recognized that this genetic mutation, which occurred millennia ago, continued to kill children and persons in Africa. And that despite being the most prevalent genetic disease in Africa, along with the serious health and socioeconomic impact, it has remained a largely neglected orphan disease in global health. Beyond its impact on health, sickle cell disease poses significant economic social costs for those affected and their family. And he did recognize that unless proper access to treatment is provided, most of the children born in Africa will continue to die to inherited blood disease. They'll continue to die very young, usually from preventable causes such as infection, severe shortage of blood. And yet we know that treatment itself is neither complicated. We can't design treatment that is neither complicated nor expensive. We can just put in policy to screen newborns or young infants for sickle cell disease. We can put in efforts at vaccination for infections. We can put in programs for simple penicillin prophylaxis, folic acid supplementation, pneumococcal, and hip vaccination, and routine follow-up visits. These steps alone, it's enough to change the narrative significantly. Now, these steps have to be offered at the primary health care level. So we have to reimagine our primary health care system. We have to revamp our primary health care system. I believe this narrative is the same across Africa. The primary health care system is largely neglected. It's not as strengthened as the other healthcare systems. And yet, this is where we have to pay attention to be able to make any dent in the data that we have with regards to morbidity and mortality or the hereditary blood disorders in Africa. So this is what Professor Mohamed Adipate put forward in 2019. He is by destiny now appointed the current Minister of Health for Nigeria. We hope that he's going to be able to walk the talk. So what are the key takeaways from my presentation? Countries with a high burden for inherited blood disorder like Nigeria, we need to adequately equip and revitalize our health system. We need to strengthen adequately our primary health care services. This is where we are going to get the people who are mostly affected, and this is where we are going to make a significant impact. we need to train and retain, because I talked about the economic immigration that we are now experiencing across the continent of Africa. We need to train and retain a critical mass of healthcare practitioners, including and essentially the genetic counselors. Establish comprehensive health insurance coverage for persons living with the IBDs, and place higher prioritization and increase investment in research and development. Every voice, no matter how small, no matter how big, can spark this conversation and action to drive the change for the hereditary blood disorders in Africa. We need to have a fresh approach to harness the political will and with science-led interventions. Collaboration with private sector entities, North-South collaboration cannot be overemphasized. South-South collaboration is even more important within the subcontinent. Philanthropists, we must improve on this collaboration, and it must be embedded in the strategies. We have to recognize the need for national movement to eliminate the barriers in order to truly ensure the unmet social and medical needs of the inherited blood disorder community. And this is where I rest my case for now. Thank you very much for your attention. So, Hova?
Yes, so thank you so much, Dr. Adeyemo, for this educative and insightful presentation. In fact, we have all learned a lot today, and we hope that we'll all follow these strategies and action points to make sure that we bridge the gaps when it comes to diagnosis and treatment, when it comes to hereditary blood disorders. Now, if you have any questions, as I said, kindly put it in the question and answer button. We will answer it later. Now, I will move straight to Megan. Megan, can you please put on your camera? Yes. Thank you, Megan. So I'll move straight to Megan for her to give us a specific presentation on hemophilia. So hemophilia in Africa, what we do not know. There's a lot we do not know. Usually we are more focused on some diseases than others, depending on the countries in Africa. So this is an opportunity for us to know more of hemophilia. So thank you so much, Megan. You are on. Thank you.
Thank you so much, Mary. Thank you, Professor Adeyemo, for that wonderful presentation. I don't know if you can see my slide.
We can see it, please.
Okay, all right. So this morning I'll be talking about hemophilia in Africa, what we do not know or what we need to know, depending on how we're seeing it. And I'll try to be fast about it in 15 minutes, but also try to get the message across. So I have no disclosures as regards this. The only thing I have is I'm a patient and also a mother and an advocate for hemophilia. So my outlines are short. Talk about what is hemophilia in more depth, some myths and facts about hemophilia, and instead of what we do not know, I'm making it what we need to know, Africa's data, and then what are the ways forward. So what is hemophilia? Hemophilia is coined from two ancient Greek words, hema, meaning blood, and then philia, meaning love of. So it was said then that hemophilia can just be said to mean love of blood. So that's how the word hemophilia came in. And it's an inherited bleeding disorders. What it means is it is passed from parents to child. It is not contagious, you cannot transfer it, and it is lifelong. You don't outgrow hemophilia, you don't get cured after using drugs for a period of time. it is lifelong. It is caused by the absence of low levels of factors 8 or factor 9. There are 13 clotting factors in the body, but the lack or low levels of factor 8 or factor 9 is why we'll say you have hemophilia. And it is characterized by prolonged bleeding and then bleeding into joints and muscles. Most times the bleeding for hemophilia are more into joints and large areas, whereas bleeds from other type of bleeding disorders are not characterized by joint bleeding. But every type of bleeding disorders, whether it's hemophilia or von Willebrand's, are characterized by prolonged bleeding. So how many types of hemophilia do we have? There are 2 types. Hemophilia A, also known as classical hemophilia, which is the result of the absence or low level of factor 8. And then hemophilia B, which is characterized, which is also known as Christmas disease. It has got nothing to do with Christmas as a result of the absence or low level of factor 9. So how do we talk about this absence? This absence can be talked about like when someone is said to have severe form of the condition, you have less than 1% of either factor 8 or factor 9 in your body, and 60% of hemophilia cases are severe. Moderate form of the condition means you have between 1% and 5% of factor levels, and this represents about 15% of cases. Mild cases have between 6% to 30%, and they represent like 25% of cases. Most times when I talk, I always try to emphasize that globally, and most especially in Africa, the mild cases are always the ones we miss out, because these are people who literally will not bleed except if there is a trauma. And so in most cases, they are mostly underdiagnosed. If you look at every data that you will see across Africa that we have now, the percentage of mild cases are not even up to this 25% in our data. Sometimes we have just like maybe 5% of our data being mild, sometimes less than that. We have more, 90%, 80% of severe cases. So we're missing out on the mild cases. Another thing also worthy of note is that though hemophilia is inherited, we have 30% that happens where there is no family history. A mutation can happen and something can go wrong when the child is developing, and the clotting factors could be deficient, could have defect, and the child can come out having hemophilia where there is no family history. And we have seen that a lot. We have so many cases where you see pair mothers and doctors are asking, is there family history? And that child is the index case in that family. Also, we need to also understand that clotting factors are on our X chromosomes. And a woman has got 2 X's, a man has 1 X and a Y. So let me use myself as an example. I have 2 X. One of my X has low level of factor 8. I actually have 28% of factor 8. And my sons were picking the defective X, the one with the low level. They get a Y from their father, and that's why they have hemophilia. One of my daughter also picked one of my defective X, and she took a normal X from her father, and she's also a carrier of hemophilia like me. My other daughter took my normal X. So we say for a woman who has a defective X gene that carries the hemophilia gene, she has a 50% chance for every pregnancy, if it's a boy, to either have hemophilia or not have hemophilia. If it's a girl, to either be a carrier or not be a carrier. It's like the toss of a coin, head or tail. Nobody knows where it's going to fall. On the other hand, for males who have hemophilia, they only have one X chromosome, and that X is the defective X. For them to have daughters, they are going to be given that X. For them to have sons, they're going to be given their Y. So daughters of males who have hemophilia are what we call obligate carriers. It's not 50-50, it's not 30-70, it's not 80-20. They are 100% going to carry the hemophilia gene. So that is the difference between a woman who is a carrier and a man who carries the hemophilia gene. So for a woman, it's a 50-50%. For a man, their daughters will carry the gene and all of their sons will be free. So that's how the inheritance of hemophilia goes in the family. And it doesn't change. It doesn't change. And this takes me to the myths and the facts. The first myth that was going around before is that a person with hemophilia, if he gets a cut, he'll bleed to death. But that is highly unlikely. People with hemophilia do not bleed faster than those who don't have. They only bleed longer. So you can see a child with hemophilia have a cut, and the bleed can prolong for as much as a week if there's no intervention. Because they will actually try to stop bleeding. The platelets plug will be formed, which will reduce the bleed for some time, but the final clot will not be formed. And at a point, the platelet will fall off and then the bleed will continue. So it's like it's off and on. So they don't bleed long faster. It's not like the gush of a tap and then the whole blood is finished. So it's highly unlikely that from a cut, they will bleed to death. Another myth is that hemophilia affects only boys. In the past, it has always been that belief that only boys have hemophilia. However, females who carry the hemophilia gene, who are known in quotes as carriers, can also suffer from bleeding symptoms. For example, I had a lot of menorrhagia. And I have an aunt who also has high menorrhagia. And that is one of the symptoms of bleeding. I bruise a lot. These are signs and symptoms. So we might not think that females have hemophilia, but they actually do. And these days we're beginning to see females who actually present with symptoms and who use treatments. We lost one who was actually our first female in Nigeria, but we currently have two that we're managing currently who are females with hemophilia. Now, another way you can have a female with hemophilia, which is not as a carrier, is if a man who has hemophilia marries a woman who is a carrier. You know, there's a defective X with the father. There is one defective X with the mother. And that means there's a possibility of having a daughter who could pick both these defective X's. And then she could actually have hemophilia. So hemophilia does not affect only boys. There are girls and females who have hemophilia. Another myth is hemophilia, everyone with hemophilia have the same level. No, I just showed us there's the mild, there's the moderate, and there's the severe. And this deficiency percentages are very important when it comes to management. So it is good to know where you fall in order for you to have a very good management. Another myth is family members can have different clinical severities of hemophilia. No. You don't see a brother with severe and then you tell me there's someone else with mild or there's another person with moderate. The gene defect that is passed on in the family is the same. So all members will have the same severity level. The percentages can be different. For example, we say severe cases are less than 1%. They might not actually be all 0.1 or 0.3, or they'll all be less than 1. So you could have two brothers who are moderate, and we say moderate is between 1 and 5%. So you could see a 2% or a 3% or a 1% and a 4%, but they will all be within moderate. So it doesn't change. Another myth is all forms of hemophilia involve a deficiency of factor 8. No. Factor 8 is a deficiency of hemophilia A. Factor 9 causes hemophilia B. So they are different. It's not every hemophilia that is factor 8 deficiency. Patients with hemophilia always have a family history. No. Like I said, patients can have, hemophilia can happen where there is no family history. Some researchers have estimated that as many as 1/3 and they identified over 3,500 different mutations in their population of 20,000 patients. So you can see there are different mutations that can cause hemophilia. So what is it that we need to know? And one is that there is huge gap in diagnosis. Huge gap. Professor Adeyemo spoke about it. Now, if you look at this data from the global survey of the WFH in 2021 global survey, we're expected to have about 97,946 persons with hemophilia in Africa. That's what the expected number is. We have just about 7,000. For example, Nigeria, we're expected to have about 20,000 of our patients. We have just about 800. So there is a huge gap. Only 8% of our population are what we have identified. Now, if you look at these graphs, Europe is close to identifying 100%. The expected is 72,000, and what they've identified is 60,000. So they are close to closing the gap. But we still have a huge gap in Africa that we need to close. We still have countries in Africa where there is a lot of cultural gaps that are not allowing diagnosis to happen. Beliefs that are making people think this has to be a spiritual thing. This has to be a witchcraft attack. But all of this has to stop. And we have to agree that prolonged bleeding has a medical name to it, and we need to begin to find help. Another thing I want us to see is this gap. And this is the need for government to take responsibility of treatment. This is also from the 2021 Annual Global Survey report. The orange line, which is showing 1 IU per capita, is a recommended IU per capita for survival by the World Federation of Haemophilia. That is the minimum IU per capita that is required for survival. Now, only Mauritius and South Africa have actually passed that. If you look at every other African country that is reporting on this global data, there's none of us that have even reached 0.5. That's first. The second thing that is worth noting here is that only Mauritius and South Africa are the countries where their government is actually procuring this treatment, either through their insurance for them. But for every other African country, they are all depending on the World Federation of Haemophilia donating factors to them through the humanitarian aid program. So what does this mean? It means that once we take off the humanitarian aid program, there is no treatment in Africa. It means that even those 8% that we have identified, when there is no humanitarian aid, they don't have a means of survival. It means that the 15, 20 years ago that Professor Adeyemo spoke about, when we are in the dark days of children dying from simple procedures like circumcision, will come back. So there is a need for us to take actions when it comes to the issue of procurement of treatment. Also, we need to know the distribution. This is also talking about the distribution of these factors. Like I said, now, we look at the population of Africa. It is 17% of the world population, but we are only consuming 1% of the total factors usage. Now, take for instance, Europe. Europe is just 10% population, but they are consuming 35% of the treatment products. America is 17%, just like Africa, and they are consuming 41% of these treatment products. So we see that we have not actually taken up responsibility in Africa of taking care of our patients, ourselves in Africa. And this has to change, because if we do not, it means we will keep losing our children, we will keep losing our women. Because permit me to say that we have a high maternal death rate. And PPH happens to be one of the leading causes. And women with bleeding disorders are at a higher risk of PPH. So who knows of the percentage of women who have died from postpartum hemorrhage? Who knows if we have a certain percentage who have bleeding disorders? And we could have saved them if only we had diagnosed them, if only we had known. So when we are talking about bleeding disorders and why we need to begin to identify these women and these patients, it's not just about other forms of bleeding. It also will help us even in bringing down the rate of maternal death. I would like to show us some realities. And the realities is all of these pictures are not from the internet. These are all persons with hemophilia. These are Nigerians with hemophilia. And this is the reality, that if we do not create more awareness in order to close the gap in diagnosis, to close the gap in management and move away from donations to actual planning, we're going to begin to see this back. We're going to begin to see boys who spend days, weeks, months out of school. We're going to be seeing boys who lose their lives from bleeding into the brain. We're going to be seeing deformities, morbidities. We're going to be seeing boys at the age of 12, at the age of 7 already on crutches. We need to be more committed. As a region, we need to own up to this. We need to stop waiting for someone to come and do it for us. One of my doctors will always say that we cannot cry more than the bereaved. We shouldn't be expecting everything to be done for us. There needs to be more commitment on our side. Commitment in advocacy, in awareness creation, and in telling people that the reality of hemophilia is there. That boy who has had his uvula removed and is gulping blood is not witchcraft, is not mother-in-law. That child who has been circumcised and has been bleeding, that person who has had an appendix operation and has bled to death, it's not everyone that is the fault of the doctor. It's not every doctor that is a quack doctor. The person had an underlying bleeding disorders and we did not know, so we did not take actions. And finally, there's a need for us to work more together. Patient advocates, healthcare providers, the society, the patients themselves, we need to work together. We need to speak in one voice. We need to let the world know that we exist and that we have the right to life. Thank you.
Thank you so much, Megan. Thank you for educating us so much about hemophilia. That was very educative and insightful. Thank you so, so much. So for the participants, please, if you have any question, please put it in the question and answer button. Thank you so much. I'm now going to have my presentation on improving awareness and education in hereditary blood disorders. So I would like to share my screen. Okay. All right. So as I mentioned my name earlier, I'm Dr. Mary Ampomah. I'm a clinical psychologist, and I've been working with sickle cell patients for the past 13 good years. And I am a lecturer at the University of Health and Allied Sciences, and I also do a lot of research in sickle cell, focusing more on psychological quality of life in sickle cell and neurocognitive functioning in sickle cell patients. So today I'm going to talk about advancing education awareness in hereditary blood disorders in Africa. I'm so happy that when Dr. Adeyemo presented and also Megan presented, one of the key things that they kept on mentioning was education and awareness. That means that when it comes to comprehensive care, one of the major areas that we should look at and be concerned about is education and awareness of hereditary blood disorders. So I'm going to, and because they've done a lot of the burden and a lot of the prevalence, I think Dr. Adeyemo did a lot of that. I will just make it very short since we have just short time. So I'm going to focus more on the overview of hereditary blood disorders, burden, very short, burden of hereditary blood disorders, preventive and healthcare provision that we have in Africa, challenges to comprehensive care, the role of awareness and education, ongoing awareness and education initiatives, challenges to awareness and education initiatives, then promoting education and awareness initiatives. And then we can talk about the way forward. Now, as we all know, hereditary blood disorders are genetic in nature. That means you are born with it, and it affects the blood. And as we all know, when it comes to hemophilia, when it comes to sickle cell, when it comes to thalassemia, it has a lot of impact on the individual and also the community and the society and the nation and even the continent at large. That means that hereditary blood disorders is something that is so key that we have to be concerned about. It's so significant and it has a huge public health concern when it comes to Africa, especially with sickle cell disease, hemophilia, and thalassemia. Now, when it comes to the burden, I think Dr. Adeyemo made mention of a lot of it. Now, when it comes to hereditary blood disorders, in Africa, we have about 300,000 babies born annually. Okay. In Ghana alone, when it comes to sickle cell, we have 15,000 children born annually who lives with sickle cell disease. Now, WHO has projected that in 2050, when it comes to hereditary blood disorders, we have about 400,000 of babies born annually. That should really make us strategize to make sure that we reduce this burden. Then when it comes to the affected people, we know that in Africa, especially with sickle cell disease, because there's not much comprehensive care in some countries, we have a lot of sickle cell patients dying before year 5. That was in the past, and because of other helpers of the work, we've reduced that rate considerably. Now, in Nigeria alone, when it comes to sickle cell disease with the traits, about 24% of the population have the traits. In Ghana, between 24 and 30% of people or of Ghanaians have the traits. In Democratic Republic of Congo, we have about 18.3% of the population, and that is really something that we should be concerned about. Now, when it comes to preventive and healthcare provision for people living with hereditary blood disorders, in Africa, we have ongoing increased awareness and education. There is supposed to be comprehensive care, which includes newborn screening, which includes access to health care, which includes therapies, which includes multidisciplinary care. Now, let's come to the challenges of this comprehensive care that we know that it will help patients live a good quality life. Now, one of the challenges that we have in managing hereditary blood disorders in Africa is mainly because of poor awareness and education, limited access to newborn screening, limited access to healthcare, limited healthcare professionals for the management, and also high cost of treatment because most of the countries do not have health insurance schemes that will help take care, or sometimes they have some on health insurance schemes, sometimes they don't. So it's not that free and it's costly to most families. Now let's look at the role of education and awareness. As I said, when it comes to comprehensive care or preventive care, education and awareness is very key. And every time that we talk about management or preventing hereditary blood disorders, this becomes a key issue. Now, if we have challenges already because the general public doesn't know much about hereditary blood disorders, and this has really increased the stigma around these hereditary blood disorders. Aside that, too, when it comes to health professionals, yes, there's been a lot of work and collaboration in that aspect, where there's a lot of collaboration between health professionals, advocacy groups to make sure, and also make sure that there's more education when it comes to hereditary blood disorders, including education to the general public, because when education and awareness is increased in communities, it leads to early detection, right? It leads to timely interventions, leads to improved management. It also, as I said, it also reduces stigma. It promotes acceptance such that it empowers the individual living with, with the community, with the condition. And it fosters a supportive role when it comes to the individual and the families. And also when it comes to educating healthcare professionals, education that healthcare professionals get and what they impact to patients and also the individual is so key. And so, increased education and awareness, make sure that there is awareness and education in these hereditary blood disorders in the society, among health professionals, among patients, among families, that will help in the management of the condition. Now, let's look at the ongoing initiatives when it comes to advances made towards awareness and education initiatives in Africa when it comes to advocacy groups. Okay, so in Africa, some of the conditions, not all, have ways of disseminating educational materials or educational information to members. Some do it face-to-face interactions. Some use digital platforms like what we are using today, and this has really helped in increasing the education and awareness around hereditary blood disorders. Now, when it comes to implementation of comprehensive and educational programs in schools and communities, yes, these advocacy groups have done a lot when it comes to these areas. Now, when it comes to collaborating with healthcare professionals in providing training and resources, yes, these advocacy groups have done a bit of it. Then when it comes to advocating for good policies in their various countries, yes, these advocacy groups have done a lot. But let's look at some of the challenges. Okay, so one of the huge challenges when it comes to hereditary blood disorders, advocacy around hereditary blood disorders, is that we don't have a unified advocacy body. A unified advocacy body patient advocacy body is so important, because then we will have a unified strategic plan that everybody can use, and wherever that you find yourself in, Africa, you can determine through research, know what is culturally acceptable in your country, and then from there you can use those feedbacks to be able to do a lot of advocacy or advocacy awareness and education around that particular condition that you are advocating for. Now, there is also a challenge with poor implementation of comprehensive educational programs in schools and communities, because we are not unified and we are fractured. We don't have coalitions. Everybody is doing everything. Okay, we are all doing everything, and because of that, we haven't really had a comprehensive educational program that we think, through evidence-based research, we think works for schools and communities. Then also, I think that we are also, when it comes to collaboration, okay, we don't really collaborate. We've done our bits, but we haven't fully collaborated with our healthcare professionals to be able to do a lot of training and also give us a lot of resources around these hereditary blood disorders. Then also, when it comes, we have also limited access to information. A lot of our members still have limited access to education. Then also, when it comes to resources, the resources that we need to be able to really go through this, do this awareness and educational initiatives well. So how do we promote awareness and education?
I'm sorry, Mary, I didn't mean to cut you, but we're about 2 minutes. We have about 2 minutes left and we still have to do the poll. So maybe if we can wrap it up more quickly.
Okay, I will. So we have to, how do we promote awareness and educational initiatives in Africa? We should have a unified patient advocacy group body, like what GANSID is doing, so that we can learn from each other. Haemophilia is there, sickle cell group is there, patient group is there. We can learn from haemophilia, we can learn from thalassemia, sickle cell can learn from them. They can also learn from us because we will all be under that one unified body. Then also, because we are under one unified body, we'll have access to trainings and all that. Then also we will be able to, as I said, because GANSID is coming out with a strategic plan, a streamlined strategic plan, we will be able to do this implementation of comprehensive and educational programs in schools and communities very effectively. We can engage in debates, quiz competitions, conferences, and workshops that will increase the awareness and education around these hereditary blood disorders. And also, GANSID has a comprehensive way of collaborating with health professionals, which we can take advantage of and also be able to have ourselves trained, able to have our health professionals trained in Africa, and also have all those resources available. Then one of the ways that we can also help improve awareness and empowerment is community engagement, which is so important. Recently, I had a campaign. I engaged all the community members. I engaged policymakers, because of the lot of the engagement that I made, I realized that there were a lot of participation. Okay, there were a lot of participation that increased even screening. Okay, I realized that a lot of the people now started going to the, hospitals to be screened. So we should really do a lot of community engagement when it comes to increasing the awareness and collaboration. Then also collaboration and research is so important, which GANSID is ready to help and equip us to be able to do. So advocacy groups, health professionals, patient families, we will be able to do a lot of research that will improve patient outcomes, increase awareness and understanding, identify the gaps, development of effective policies, and also advancement in research as we move forward. So what is the way forward? We should have a unified advocacy body. We should all support GANSID. We should be part of GANSID to make sure that no matter where a child is born with any hereditary disorder, they will be diagnosed and they will have comprehensive care. Then also all the support groups in all countries, we should come together to form a coalition. Let's form a coalition. Let's work together so that we'll be able to champion whatever mandates that we have for our various countries, and we'll be able to push for positive policies. Then when it comes to funding, the way forward, I just realized with my campaign that I could also seek a lot of funding in Ghana. I don't have to go beyond Ghana that much. So I think we should all take advantage of that. We should come under one umbrella. We should push. There are a lot of, as Megan and Dr. Adeyemo said, there are a lot of people suffering. There are a lot of people going through a lot. Let's form a team. Let's come under GANSID. Let's do what we are supposed to do. Support GANSID to be able to do this effectively, not just in Europe or America, but also in Africa. Thank you so much.
Thank you so much, Dr. Ampomah, Dr. Adeyemo, and Ms. Megan. A great presentation for sure. Folks, I know we are a little bit late, but this is a very important discussion. And I see a few hands raised. I'm wondering, is that new hand or is that old hand? Judge Roberts, would you like to speak? I can unmute you quickly if you'd like to speak. Okay, maybe it's an old hand. That is fine. So,
speaking sure. On behalf of Sierra Leone, where we have lots of patients with sickle cell disease, and we have a charity that provides care for patients with the disease. But the important message that I've got is that there has to be a lot of advocacy and a lot of public involvement. We are doing this, but it's not quite enough. And we cannot do all that is necessary unless the government of Sierra Leone gets a hand into the treatment and management of individuals with sickle cell disease and other inherited blood disorders. By the way, I want to tell you that we have not been able to identify individuals with bleeding disorders in Sierra Leone. The reasons for that are complex, and we needn't go into that now. But I think some of the things I've learned here this morning hopefully will enable us to move forward with the bleeding disorders in Sierra Leone. Thank you.
Thank you so much, Dr. Robert. We have the poll open. Folks, if you can please complete the poll so we know what we've done right, what we need to improve on, that will be helpful. But to come back to your comments, Dr. Robert, I think
Larry, can I just
identify? I'm sorry?
Can I just chip in something for Dr. Roberts?
Yes, I will. I would like to. I just want to also,
all right.
But before you go, and I want to say that we have not been identifying them. You have not seen them because you have not been identifying them. And this is why it's important to have, a collective, how do I say this now? A collective strategy in how we advocate to ensure that whether it is bleeding disorder, thalassemia, sickle cell, these babies, we can identify them and we can adequately treat them. Like, Ms. Megan said earlier, we can't rely on World Federation of Haemophilia to be giving the treatments, to be giving the factors and all of those things. Government has to be involved, and it takes advocacy to do that effectively, and we will be connecting with our patient organizations in the different regions of the world to see how we can push advocacy in their own region to ensure that no matter where you live, no matter what your disease is, if it's hereditary blood disorders, you should have access to the right care at the right time. So I would let Ms. Megan respond also to Dr. Roberts on that. Thank you.
Thank you so much, Larry, for this opportunity. Thank you, Dr. Roberts, for that. I'm going to actually drop my email in the chat box so that we can take these discussions beyond just this place. I was actually in Sierra Leone in August to launch Haemophilia in Sierra Leone. And I just got a WhatsApp message. We just sent factors for a 1-year-old boy that has been bleeding to his joints. in Sierra Leone for the past 1 week. So you actually have patients. There are about 9 patients I saw when I came in August. So, and there are 2 people who are working. So we could network you together with them so that you guys can work together better. Thank you.
No, that's
that. Go on, Dr. Roberts. I love that.
Yeah, that's absolutely marvelous. I've been trying for years and years to get any information about patients with bleeding disorders, but without any success. Obviously, things have changed a bit, and I'd like to follow up on that.
Yes, I just dropped my email for you in the chat box.
Okay, thanks.
We also have Dr. Mary Ampomah. Raise your hand. Mary,
yes. So, Dr. Roberts, thank you for your feedback. I think I want to add a little bit of what Larry said. I remember 2 years ago, we went to see our Minister of Health in Ghana so that we can look at some policies that we think that, especially with the newborn screening policy, one of the things that he said was we should go and form a coalition. So as Larry rightly said, not just sickle cell coalition, but hereditary blood disorder coalition, where when you come, you have a big front and you would have a bigger voice where government cannot say no to you, because when we come together like that, we have the numbers, we have people talking, and we can champion whatever mandate that we need in our various countries. So thank you.
Thank you so much, Mary. And I know we have more people that want to talk, and I will let you do that. But I just want to give a Canadian example of how this has been very helpful. So the Thalassemia Foundation of Canada and the Sickle Awareness Group of Ontario, we do a lot of advocacy together with the government. I'll give you an example. You must find, for instance, a commonality of purpose. What is the one thing that can benefit Haemophilia, Thalassemia, and sickle cell? And let's go to the government together and advocate for it jointly. That's what we're talking about here. There will be some situations whereby you will have to do disease-specific advocacy, but there are those situations that cross disease advocacy is what you need to do. So for instance, in Ontario here, where I live, we have 7 centers of excellence for hemoglobinopathy, for sickle cell and thalassemia, and other rare anemias. And so what did we need? We need more staffing to make these centers even more comprehensive. So we joined together, went to the government together and said we needed resources for her clinic. Has hemoglobinopathy, association, like a collective. They listen, because it's not just sickle cell going by itself, thalassemia going by itself. So we must find what are the things that we can do together, we can push together. And that's one of the things that we're going to discuss in our next membership regional meetings, to talk about for each region, what are the needs? How do we tackle it together as a collective? It's so, so important.